ladies and gentlemen, I would like to talk about the dense fractures in patients over the 65 years of age. Incidence of these fractures is from 7 to 15%, and it represents at about 60% of all C2 fractures. There are most common cervical spine fractures over the 70 years and most common fractures over the 80 years. The non-unions are described in literature 2.4 to 82% according to type of treatment. In our institution, we prefer the surgical treatment for all type 2 and type 3 fractures regardless of the age. The conservative treatment we prefer just for the non-displaced or completely reduced fractures in the young patients. All patients over the 65 years are enrolled into the study with direct osteosynthesis of the dens or posterior atlantoaxial fusion. Between 2001 and 2005, 28 patients was treated. There were 13 men and 15 women with mean age 77.4 years. We divide the whole groups into the subgroups according to the type of surgery and according to age of the patients. Isolated fracture of the dens was present in 23 patients, complex injury of the C1, C2 in 5 patients. We had just 3 patients with a neurological deficit. In our institution, the method of choice for this fracture is surgical treatment by direct osteosynthesis with 2 cannulated screws. In case of the osteoporosis or comminuted fracture of the dens base or tear of the ligamentum transversum, we prefer the Harms method of posterior fixation or Magerl's transarticular fixation. We followed up at 3, 6, 12 weeks all patients, then at 6 and 12 months, and then at 1 year intervals. The whole group were evaluated in the range of 18 to 84 months. Average was 37.7 months. X-rays were made at the regular follow-ups and functional radiographs at 12 weeks. The results were analyzed using the Chi-square test. It's example of one of our patients is direct osteosynthesis, and one more example, posterior C1, C2 fusion according to Harms. In the younger group, we had 3 direct screwings, 4 Harms techniques, and 1 Magerl and Gali technique. We have no neurological deficit and 8 fusions after 3 to 6 months. We have no deaths and no major complications. In the older group, had 11 direct screwings, 8 Harms techniques, 1 Magerl and Gali, and we had 3 neurological deficits, Frankel D types. We found 8 deaths, 1 within the first 3 weeks and 7 within the first 6 weeks. We found 10 fusions and 12 stable C1, C2 segments after 3-6 months, and 1 non-union and 1 fiber skulls after this time. In the older group, we had several complications. 1 excessive bleeding from the plexus around the second nerve root, no vertebral artery bleeding, no nerve structure damage, 1 wound healing problem, the solution was resuture, and 2 times caudal screw dislocation. 20 patients still living at the time of evaluation. In 11 were underwent direct osteosynthesis with 1 non-union. In 9 were treated by posterior instrumented spondylolysis with 1 fibrous callus. No significant difference. Mortality in the younger group was 0, mortality in the older 40%. It's a significant difference, and mortality in the direct osteosynthesis group was 21. In the posterior fusion group, it was 35%. No statistically difference. We concluded that surgical treatment can significantly improve the quality of the life in elderly patient. The surgical technique should be chosen according to the bone quality, degenerative changes of the spine, and overall health status of the patient. And mortality after surgery is not related to the technique but to the patient age. And elderly patients with neurological deficit usually die due to the comorbidity regardless of the therapy used. Thank you for attention.